to have a device that works as good as rotablator and it's not as cumbersome as rotablator. So that's where orbital atherectomy fills it. Like you would always want to have calcium ablation followed by a balloon based strategy. So whatever you have mentioned, it's primarily a balloon based strategy. So you want to ablate, you want to remove the volume of calcium from a particular lesion, you want to remove at least 50% of calcium sitting over there and then break it open with a balloon based strategy. So regarding balloon based strategy, we have all these cutting balloons, scoring balloons, you have the NSC Apata, then we also have OPN and the super high pressure balloons like OPN as well as IVL balloons. So that would probably be a second half of managing calcium, and the first half would be an ablative strategy wherein orbital atherectomy and rotablator would be the reasonable options.
Perfect. So, as Dr. Deepak mentions that going for a ablative strategy and then going on with a balloon-based strategy works pretty well for calcium modification, and definitely because of the lower, lesser steep curve for learning in orbital atherectomy, it just scores over rotablation. Sir, apart from large caliber vessels and aortoostral densely calcifications, why orbital atherectomy is not the first choice for many of us, despite having consistently shown similar outcomes as rotablation? Theoretically, has even more lumen gains with the same single crown. So why do you feel that it's not just as picking up
the penetrance?
The penetrance
primarily because this is a device that's available in India only for the last 1 year or so.
Okay.
And everyone would want to have a feel of it. Everyone would want to listen to the data with orbital atherectomy, and everyone would also want to see at least few interesting cases wherein this has worked out really well. So probably it takes 1 or 2 years for it to pick up. That should probably be the reason, because primarily I feel that for some youngster who is about to start his calcium modification, he would always prefer using an orbital compared to rotablator because it's less cumbersome device. You can have it easily done through the radial approach, you can have it done through the 6 French guide catheter. Then again, you don't have to have multiple sizes. It just one size fits all. You just have one device. You can have maximum plaque modification with the same device. Unlike rotablator, wherein you'll have to start off with an 1 point. When you have a heavy calcification, you need to start off with at least 1.5 millimeter bar. Then probably you have to step up to 1.75 and 2. Probably everyone is not happy using 2 bar because slow flow can happen. That sort of difficulties could happen with rotablator. So everyone would probably prefer using orbital atherectomy in the near future, but then probably it's just the teething problem. Everyone should have a feel of it before they start using it. That's what I hope.
So absolutely, not everybody is an early adopter for the technology or the things we have in our armamentarium, and that's perfectly fine. So having data on our side and gaining some experience also is a perfect way to go ahead. Sir, should the seasoned rotablator who has done rotablation for past 20 years and has done only rotablation as calcium modification strategy all his life, should he learn the new skill of orbital atherectomy, or should he change his practice now?
Oh, certainly, that's a very good question, Abba. I've been using rotablator for the last 12 years, and we have fairly good experience using rotablator in most of the difficult lesions. But then we do have problem with rotablator. Let's say when you have a huge vessel, let's say you have a left main, wherein you have a good nodule over there, you have an eccentric plaque over there. Unless and until you have a wire bias towards that particular nodule or near the eccentric calcium, rotablator may not help in those subset of patients. So when you have a huge vessel, when you have nodular calcification, when you have eccentric calcification, those situations probably orbital atherectomy has got an edge over rotablator. So certainly it's like whoever is well versed with rotablator should probably switch over to orbital atherectomy, because probably 50-50 at some point of time you might switch over to 50-50, and it's a less cumbersome device, 6 French catheter. So every time I do a rotablator, by choice I would prefer going through the femoral approach, or if not possible, at least a 7 French guide through the radial approach. So that probably could be avoided if you are going with a planning to have it done with a orbital atherectomy, unless until you have a bifurcation stenting, heavy calcification bifurcation, you need a 7 French guide catheter. Most of the situation you can get away with a 6 French guide catheter. So I think probably everyone who is really into rotablator, whoever is very well versed with rotablator, who is very comfortable with rotablator, still they would prefer switching over to orbital atherectomy at some point.
Perfectly placed. I think the message he wants to say is that not only the compliance of the arteries is important, the compliance in the mindset of the interventional cardiologist is also important. You should change as the technology improves, and definitely, as per Dr. Deepak, the technology and the ease of usage of orbital atherectomy is absolutely on par, if not better, than rotablation. Sir, how do you like the CRISP conference, sir?
Oh, it's really great. That's what I was trying to convey. Like orbital atherectomy is there in the market, Indian market, for the last 1 year. Now, only very few people have been routinely using orbital atherectomy. So, with these sort of conference, probably the penetration of newer technology should be much more, because it's a huge conference. A lot of youngsters have joined here. These youngsters would always want to avoid rotablator in their cath lab, because at least few of them, they'll be working in a center wherein they do not have a cardiothoracic support, but still they want to have a calcium modification device there. They would also want to have a procedure done without referring them to a tertiary center. So now, with these sort of conference wherein you have enough and more of time for discussion in between every presentation, you have a lot of time for discussion. So that's where everyone would gain, like the delegates would gain, like. So these youngsters are definitely going to gain with this, how exactly these newer devices work and all. It's going to be really beneficial for them.
Perfectly put, sir. And a few rapid fire questions, sir, to end. You may choose to answer whatever you feel like, sir. Sir, intravascular.
What about the rest of the question?
Sir, will be. You have already answered.
Whatever rapid fire, whichever I don't want to answer, I just keep
yes,
quiet.
you can skip also, sir.
Thank you so
Absolutely
much.
perfect for that. Sir, intravascular lithotripsy or rotablation, sir?
Both are different. Both are different, because
You have to choose one, sir.
Yeah, if I were to choose one, for a superficial calcium, it's always rotablator, because the cost is going to be less, and it's a predictable device, because we do have failures with IVL also.
Perfect. Rotablation or orbital atherectomy?
Again, there are niche indications for orbital, and you have indications for rotablator also. Let's say when you think in terms of rotablator, when you have a diffuse disease, probably rotablator goes over orbital, and when you have somebody with hemodynamic compromise, you want to have a quick procedure done, rotablator would be the first choice. But then when it comes to orbital, you have a large vessel, you have a nodular calcium, you have still an uncrossable lesion. Those situations and all, orbital would be much better compared to rotablator.
Third question, completing the triangle, IVL or orbital atherectomy?
And again, it's the same answer, because both are different. Let's say we are just talking about superficial calcium. If you want to have maximum volume reduction, it's going to be orbital compared to IVL.
Okay, sir. The PCI or medical therapy in a stable angina?
Best option in a stable angina patient, it's always conservative management. And youngsters, probably we would straight away prefer having an angiogram done for them. Elderly, always it's conservative management. If they do not respond to medical management, it's going to be PCI or CBC.
Perfect, sir. Sir, triple vessel vein grafts in 2024, triple vessel vein graft bypass surgery versus triple vessel angioplasty image guided.
Certainly, I hope with the newer modalities for calcium modification, with imaging modality, and with newer stents that's available in the market, probably I would say that compared to 3 vein grafts, 3 stents would be better for
3
them.
stents will be better. And to end, it's a tea or coffee?
Coffee.
Coffee, again a coffee person. So we have a list, it's growing by the day. And thank you so much, sir. And it was very nice talking, sir.
Thank you so much.
Thank you. Thank you, sir.